I'm excited about talking about cancer rehab. When I was talking to Claire earlier, she said, I've never heard of you. And I said, well, that's because I actually work mostly with stroke. And my research has, up until a couple of years ago, has been mostly with patients who've had a stroke. And when I went to work at St. John's Rehab Hospital, which has recently merged with Sunnybrook, so we're now Sunnybrook St. John's, I found out that there was a little inpatient oncology rehab program, and it's been in my head for a while that cancer is a chronic condition. It's becoming more of a chronic condition, and it's something I'd like to look into. So that's where it started a couple of years ago. And we're certainly not at the same place in cancer rehab research as we are in stroke rehab research. Stroke's always been considered within the realm of rehab and a chronic condition, or maybe not always, but at least for 3 or 4 decades. And cancer rehab is really at a much different stage. Oh, that worked. So I have a lot of slides, and I put a lot of information because I'm not 100% sure what you're all interested in hearing about. So I might get to some slides and ask if you want me to talk more or less about it. So let me know. I'm happy if I'm telling you something you've heard before, just tell me to move on. So I want to talk a little bit about the language of rehab, and just because we do have a different language than the medical world, and sometimes when we rehab people say words, it's the exact same word, but it means different things to us than it does to other people. A little bit of an overview of cancer rehab in general. Talk about maybe some future directions for cancer rehab research and education, and then discuss the current situation in the Southwest. And that will be you guys, because I don't know what the situation in the Southwest is. That'll be our last 10 minutes. So the language of rehab. Just start with a definition of rehab. There are many definitions of rehab. This is one that came from the Managing the Seams document from a working group in rehab in Ontario in 2000. And it's adapted from the World Health Organization definition. It's not necessarily everybody's definition, but it's a good start. A goal-oriented and time-limited process which enables individuals with impairments, activity limitations, and participation restrictions to identify and reach their optimal physical, mental, and/or social functional level through a client-focused partnership with families, providers, and the community. That definition came from World Health Organization. I want to talk a little bit about the ICF. Are people, the International Classification of Function, are people familiar with that? Does anyone not familiar with the ICF? Okay, so most people are not familiar, so I will talk about it. The ICD, the World Health Organization, has 2 classifications. One is the ICD, which probably most people have heard of, that is essentially labels diseases, and you see them in hospital charts, ICD codes, and it says you have a disease or a condition or you don't have it. The outcomes are sick, not sick, dead or alive. They're very basic outcomes. The ICF is the International Classification of Functioning, Disability, and Health, and it defines the consequences of disease. So it goes beyond just has the condition or doesn't have the condition. It tries to look at what are the consequences for living with that condition. It talks about body functions and body structures, which we also call impairments, activity and participation, and those items are all within an environmental and personal context. It was developed in 2001, and it's considered to be a biopsychosocial model of disability, looking at disability through both medical and social lenses. And this is just a framework of what it looks like. So the health condition or disease is at the very top, and then feeding into that or an interactive relationship exists between the impairments or body structures and functions activity, and participation. And again, all in the context of environment or personal factors. Activity and participation are sometimes a little bit difficult to understand separately, and there's been a little bit of controversy about how participation is viewed, but one way we can look at activity and participation is this. Whereas activity can be viewed as what a person is capable of doing under the best possible circumstances, participation can be viewed as what that person actually does. So the definition of participation is involvement in a life situation. And we have sometimes situations where people can do an activity, but they don't participate. And we have reverse funny situations where people participate, but they can't do an activity. So an example is, let's say I'm very capable under ideal circumstances of getting up in the morning and getting dressed and getting on the bus and going downtown. So I can do all of those activities. I can get out of bed, I can get my clothes on, I can get out of my house, and I can get on the bus. Whether I actually do that or not is the participation piece. So there might be family factors that are preventing me from doing that. There might be motivational factors that are preventing me from doing that. Even though I am capable of all those activities, I might not be participating. I could have a situation, one of my kids accused me of being a creeper because I was taking a photo of somebody, and so I didn't use it because of my child's accusation, but in Aurelia where I live, I see sometimes this lady who has a scooter and she walks her dog. So she can't walk, but she can walk her dog. She can't do the activity, but she participates. And so I don't have a photo of her because it's disturbing my children. This is an example of how it might look with cancer, this Icf framework. This is from Kristen Campbell, who's an assistant professor of physical therapy at UBC, and she's given me permission to show this. At the top, the health condition is breast cancer and the effect of cancer treatment. And in the body functions and structures, we see things like decreased mobility of the arm, pain, decreased cardiorespiratory fitness, decreased muscle strength. At the activity level, or these would be actually activity restrictions, decreased ability to lift and carry objects, decreased ability to reach, decreased ability in self-care. And at the participation or involvement in life situation level, decreased ability to engage in work and leisure, and difficulty engaging in interpersonal relationships. The environmental factors would be social attitudes, access to services, and personal factors include things like age, coping styles, social background, education, and employment. So the idea is that these things all interact. So you could have better or worse activity and participation depending on the health condition itself, how the body functions and structure impairments are acting, and because of the environmental and personal factors. The goal of rehabilitation is to move people towards better functional health, complete functional health. So complete functional health, using again these terms from the ICF, against the background of environment, a person's body functions and structures correspond to accepted norms. A person executes or can execute any activity in the manner or to the extent that is expected of someone without the health condition, and they're participating in the life areas they wish to participate in. Not that everybody gets there with rehab. That's the goal is to move people as close to that as possible. And sometimes the goal is to prevent them from sliding backwards away from that too fast, or to maintain. Who needs rehabilitation? Anybody who has activity limitations or participation restrictions, or is threatened by possible activity limitations and participation restrictions. There are a number of factors that can influence functional health in cancer, as I'm sure you all know. And these factors lead to things that we can remediate in rehabilitation, things like pain and fatigue, cardiovascular deconditioning, weakness, loss of joint range of motion, anxieties, nutritional deficiencies, decreased bone mineral density. Those would be considered the impairment level things, and they all act together sometimes to decrease functional health status, decrease life participation, decrease quality of life. So are we good so far? Any questions? Okay, so I wanted to give an example of somebody who went through a rehab program. This is a person who had a diagnosis of natural killer cell lymphoma who's now living at home, or is not now living at home at the time of this writing of this case example, and is in remission. So from a medical perspective, this person is a success. They're in remission and they're living at home. If we look at the functional profile of this person, however, we see that it's maybe not such a success. He's home because he has a lot of help from his family and from CCAC, and he's in a financial position to pay for private help. He's non-ambulatory. He's dependent in all his functional mobility, including bed mobility. He cannot roll without assistance. He can't move up and down the bed. He certainly can't transfer without assistance. He's dependent in all of his activities of daily living, bathing, dressing. He can sometimes feed himself if he's not fatigued, but not always. He has nutritional supplements. He can tolerate sitting in his chair for about 10 minutes. And he's dysarthric on top of it all. He has very slow, difficult communication. So from a functional perspective, the consequences of disease perspective, he doesn't look as good as he does from a medical perspective if we just consider that he's in remission. So this gentleman was lucky enough to get into a rehab program. He did make some progress in rehab. He went from having no voluntary movement to some weak voluntary movement of all limbs. The big one was that he was a mechanical lift transfer, and he learned to be do a standing pivot transfer with assist of one person, which his wife was able to do. She was strong and healthy enough to do it. He learned to improve his speech enough to communicate with those who are patient with him, and he learned to use the commode for toileting. So all of that meant he was able to go home. Even though there's a tiny little functional gains, they made the difference between staying in the hospital and going home. The biggest one probably being the fact that his wife was willing to do the transfer and was physically able to do the transfer. A significant functional improvement. This gentleman did pass away. Did have a recurrence and did pass away eventually, but he did so at home, and it was as he and his family wanted it to be. This is the other end of increased functional health. This is the other end of the spectrum. This is a gentleman who had a testicular cancer, had a surgery only, had a recurrence about a year later, and then underwent a very aggressive chemotherapy regime. And 18 months later, after that extremely aggressive chemo where he was, completely deconditioned, finished Ironman USA. So that is also an improvement in functional health. That is what this person wanted. That's what some people are capable of. So this is the range of rehab. We can take somebody who just wants to get home, or perhaps go as far as doing something that most of us do not have on our to-do list. Any comments so far? Questions? Okay, I gotta grab another sip of water before I get into the next piece. Yep.
So the ICF that you're talking about, is it a codified system?
Yes.
So for research purposes, it's
it's in the European countries, I think they use it more for research than we do here. It has many different uses. The ICF, it is a framework and a coding system. I think because it's a little bit controversial, and because the activity and participation piece was never really well, particularly the participation piece wasn't well operationalized around 2000, 2001 when they were developing this framework, which is a replacement of a previous system. It hasn't been adopted as much in North America as a coding system, but where we have agreement, I would say internationally, is in the language, using the language. It's really given rehab people a nice common language to use. And there are tools that have come out of the coding system and framework that are separate spin-off tools, but do use the coding framework. And it's all online and easy to access. So as I'm part of a little group that has on it an OT, Mary Egan, who's a prof at University of Ottawa, and Martin Chasen, who's a palliative oncologist also in Ottawa, and Margaret Fitch, who's a nurse at Sunnybrook at Odette. And we've been working together for a couple of years since I started at St. John's to do a number of projects looking at interdisciplinary cancer rehab. And the four of us ran a meeting in the spring, which I'll tell you a little bit about later on. One of the things we did as preparation for the meeting was conduct a literature synthesis led by Mary on current best evidence in cancer rehab. We started with a review article from 2011 by Richardson that looked at a number of survivorship domains, and we looked at those through a rehab lens and added some domains to it. And looked at literature synthesis pieces that have occurred since that 2011 review. So what you'll see here that I'm reporting on are only, you may know of research in an area that doesn't appear here. I may show a slide that says, doesn't report on a piece of evidence you know about. That would probably be because it's not considered quite strong enough yet. It's not part of a meta-analysis. But this is what we found. So we found that there's good evidence for, in the physical functioning domain, for use of exercise and other physical rehab techniques to reduce fatigue in a number of cancer populations, and specifically to improve upper extremity functioning in individuals with breast cancer. With fatigue in particular, the evidence suggests that supervised programs are of benefit, but not unsupervised programs. In terms of pain, I have nothing on Tai Chi, but some preliminary evidence for short-term effectiveness of massage and acupuncture. And the findings would suggest that TENS is effective to reduce bone pain on movement, but not chronic pain in palliative patients. Sexual functioning comes up in every single review, in whether you're looking at it from a survivorship perspective or a rehab perspective, as being very, very badly understudied. It's been several years now that it keeps coming up as something we need to look at more. There is some preliminary evidence that face-to-face psychosocial interventions may improve sexual functioning in men with prostate cancer. In women with gynecological cancers, longer psychosocial interventions, 12 sessions, can improve sexual functioning more than short, as in one session. And there's some very preliminary evidence on pelvic floor retraining in sexual functioning in women with gynecological cancers. Cognition is another area that has been understudied, but we're starting to see more work on that now. Cognitive retraining interventions tend to lead to improvements in subjective memory, but not necessarily objective scores. Interventions based on self-regulatory cognitive rehab show some promise, and relaxation strategies may improve attention following breast cancer surgery. Depression, and you'll see some of these domains obviously are not strictly, they're not strictly the role of rehab. We overlap with lots of people. Moderately good evidence that cognitive and behavioral therapies and collaborative care improve depression among cancer survivors. There's some pretty good evidence on return to work, multidisciplinary interventions involving physical, psychological, and vocational components. Nutrition, there isn't actually tons of good synthesized information on specific diets. Where we did find a little bit of evidence was around swallowing, which we put in with the nutrition piece, in head and neck cancer patients. Head and neck cancer patients who received 12 sessions of structured swallowing following tongue resection had less dysphagia. And participation is a piece that we added that was not in the Richardson review, the 2011 Richardson review. There's certainly evidence that participation restrictions are a problem among cancer survivors up to 5 years plus post-treatment, but we didn't find any RCTs, reviews, or guidelines addressing the problem. So this piece of that we would call involvement in a life situation, which is where we'd really like to go in rehab. I wanted to tell you a little bit about the program we have at St. John's, our little 6-bed inpatient rehab program. So I think I'll go there, and then I think I'll come back to the meeting that we had in the spring where we developed consensus statements on rehab. Is that okay? Okay, so our program started in 2008 before I was there. It was started as a pilot project with Sunnybrook when we weren't part of Sunnybrook, because there was a need identified at Sunnybrook for rehab. And I think I've spoken with some of you in the room that often when it's identified that a patient could benefit from some rehab services, there's nowhere for them to go. That often if you apply to a rehab program and they see the cancer diagnosis, they'll say, oh, that person's not eligible for rehab because they have cancer. And there's a bit of, so we in rehab complain sometimes that it's the oncology side that doesn't understand what rehab can do, but we're aware that there's a problem on the rehab side of people saying, oh no, we don't do that. So that need was recognized at Sunnybrook, and they approached St. John's because we're relatively geographically close, and said, why don't we try this as a pilot project? Why don't we carve out some beds for an inpatient oncology rehab program? It can be for anybody. It's not a specific cancer diagnosis. It's any cancer diagnosis. And they did it for a few months, and it was very, 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 very successful. And they then opened it up to referrals from anywhere. So I did, when I got to St. John's, one of the first things I did was look at just a basic retrospective chart review just to find out what's going on with these patients. And we went back 18 months because it was the data we had at the time. So just first of all, why inpatient rehab and not outpatient rehab? And in Toronto, in the GTA, inpatient rehab is considered suitable for patients who need an interprofessional program rather than a single service, and also require 24-hour hospital care. So our admission criteria, and these have evolved a little bit over the years, but they're basically the same as they've always been. It's for any patient who's undergone or is planning surgical or medical treatment for cancer. So the is planning piece is interesting. You may have heard it called prehab in some places where, and at our program they call it buffing up. So sometimes they do a little bit of buffing up before people go in for another round of treatment so that they can better withstand the next round of treatment. We don't have a lot of people coming in because the need has been so great just for post-treatment. We don't use and we only have these 6 beds. And there are other cancer rehab beds in Toronto, but they're specialized for, Toronto Rehab has a program for anything that's a little bit more musculoskeletal bone cancer related, but we're the only ones that have general rehab beds. So we haven't done the prehab very much, but it does happen occasionally. Our patients need to be medically stable, no fluctuations in the past 72 hours. They need to be motivated, have active rehab goals. able to participate in 2 sessions a day, 5 to 7 days a week, because we do provide weekend care. Not for everybody. It's not the same as the Monday to Friday care, but some people do get care on the weekends. They need to sit unsupported for 30 minutes. So my original case history would not have qualified for this program. This one we've left a little bit vague on purpose. Cognitive abilities and mental health sufficient to support active rehab. They had originally had some more specific definition of what that meant. And they were finding that it wasn't quite fair, and they're leaving it more up to the judgment of the acute care staff as to whether they think they have the cognitive abilities and mental health to support active rehab. I mean, one of the main reason for coming to rehab is general deconditioning. It's not like a stroke program where you need to learn to walk. That's not true. Some people have specific skills they need to learn because we take all cancers. But the overwhelming reason is deconditioning. So sometimes they don't really tolerate 30 minutes. Completed or on hiatus from radiation or IV chemo, we do support oral chemo. And we do accommodate some special needs, IV therapy, O2, trachs, tube feeds, ostomies, and we can accommodate dialysis off-site. So just to give you a little bit of an overview of who we found is coming to our program, 60% women, older women. Our average age was 72, almost 73 years, and 40% living alone. So to me, this is probably not a lot different than what we might see on a inpatient stroke rehab program, or a musculoskeletal rehab program where we have a lot of hip fractures. Who comes to inpatient rehab in those programs? Probably mostly older women who live alone, which is what we're seeing here. So in that case, it's a similar profile. Our mean length of stay is about 3 weeks, which is similar to our other programs. And we saw a wide range of cancers. So about 30% colorectal, 15% metastatic disease. We lumped anybody with metastatic disease together, and 7% bladder cancer. Those were the top 3. This is a slide showing all of them. You can see there's a whole range, and we have this big other category, because I don't even know how many separate diagnoses there were altogether, but we had many, many, many different types of cancer diagnoses. The other is particularly interesting because, we thought we would see more. We had a lot of colorectal. We thought we'd see more breast, lung, and prostate cancer being the other 3 of the big 4, but prostate cancer was on the other slide, but I think only around 3% of our total number of patients. Only 2 breast cancer patients in 18 months, and only 1 lung cancer patient. So we're not quite sure why that is, but it was a little bit interesting. Probably just referral patterns. Maybe the patients with breast cancer are a little bit younger and having more family support to go home. I'm not sure. This is one of those slides where I was going to ask you if you want me to explain it or not. Who would like me to explain the FIM, the functional independence measure? Does everybody know what that is? Not so much? Okay. So we use this thing in rehab called the FIM. We don't all love it, but we use it. And it's our main outcome measure. It's mandated in a lot of situations. It has a motor component and a cognitive component, and each item is scored on a scale of 1 to 7, with 1 being complete assistance and 7 being fully independent. These are the domains. I think you have that on one of your slides. So it has 18 items total, many more items in the motor domain than the cognitive domain. And this is what we found. Our patients improved. They had clinically meaningful and statistically significant changes from admission to discharge on the FIM. So the purpley, bluey bars are admission scores, and the more pinky purple bars are the discharge scores. What's interesting here is the total FIM change was driven entirely by the motor score. There's no change in the FIM cognitive score. And that doesn't really tell us anything except that Jennifer will probably agree with me, the OT in the crowd, that the FIM's really lousy at measuring cognition. So what happened was the FIM score, the total FIM cognitive score is about, I think it's 35. Our mean was 33. So we had people really maxing out on the FIM cognitive. We don't know if this means our patients don't have cognitive issues or if the cognitive issues are not being picked up by the FIM. So that's an area that needs to be fleshed out a little bit more. This is another interesting piece. So I said when I first started talking about our program that we have this group of older women who tend to live alone, which is probably not that different from other inpatient rehab populations. This is where we do see a difference from other rehab populations. We have a very high discharge rate back to acute care. 22%. Now, in the general inpatient rehab population, it's about 9 or 10% who go back to acute care. We have 22% going back. So the dark green is home with some kind of a services, the light green is home without services, and the blue is some kind of assisted living. And the big yellow is the percent that goes back to acute care. This is not unique to our program. This is something that's been described in the literature in other rehab programs. It's a more fragile population than some of the other people coming to inpatient rehab. So that's something that, and that's one of the things that was very frustrating for the rehab staff because they weren't used to this. They weren't used to having people that maybe would be fine one day and then all of a sudden be sick and have to go back to acute care. Just a really quick, this is a nice little qualitative study that some of the PT students did this year, and we're just getting ready to submit it. They called it Getting Back on My Feet, the patient perspective of inpatient rehab oncology, and I'll just give you the one quote that the study title came from, or the manuscript title came from. It's rehabilitation so you can get back on your feet. Natural, I felt good about it. You know how long you're waiting in your bed. You feel sorry for yourself, you know, just because you've got cancer. You want to get up on your feet, get up and enjoy the old earth. The expectation was to get on my feet, to rehabilitate myself, to motivate myself. It was a chance to get better. So this is the meeting we ran in the spring in Toronto. And it was great. We had 29 people come from across Canada, a lot from Toronto, but we had people come from all over the country for 3 days, and it was a working meeting. Everybody who came either presented on their work or their program, or else facilitated a panel discussion. So even from the first day, everybody was working, and then we did small group and big group, and it was very tiring, but at the end of the day, we developed consensus statements for research and education in cancer rehab. We did have at least 2 survivors at the meeting as well, among the 29 participants. The statement we came up with in terms of moving forward with research, keeping in mind that we use the best evidence synthesis as a backdrop for this, there's definitely good evidence that rehab interventions are effective in a number of areas, but what we know right now is very broad. We know that generally exercise works. We know that interdisciplinary rehab interventions generally help to improve people's function, but we don't know a lot of specifics. So the priority now is to look at what's happening more specifically. So to develop and test personalized rehab interventions and short-form instruments to detect presence and severity of disabling symptoms, specific to different types of cancers, specific times in the trajectory, and meshing with individual patient characteristics. That last piece is the important piece. That's what we don't know right now. We don't know necessarily that if something works for people with one type of cancer, that it might work for people with another diagnosis. Or we don't have a lot of details about how early can you start doing more intensive rehab interventions. During treatment, do you need to wait till after treatment? Does it depend on what the treatment is? So there's quite a lot of work to be done there. But generally, we know that it's effective and safe. This was the framework that we came up with. So at the center, personalized rehab interventions and instruments that tell us more about what the disabling conditions are for that individual. And to feed into that, we need some patient-specific information. There was a consensus that we really need to go to the basic and clinical sciences, that sometimes in rehab we have a tendency to avoid the basic sciences a little bit, and we need to look at the health systems within which we're working. We need to look at, on the other side in the blue, functional and participation outcomes and knowledge translation pieces, and those knowledge translation pieces and outcomes need to feed back into the intervention so that it's an iterative process. In terms of education, the people at the meeting really had a number of backgrounds. We had traditional rehab people, we had medical people, nursing, psychologists, sociologists, survivors. There was a consensus that we don't really have a handle on the scope of rehab. So we need to have a description of the nature of cancer rehab and its mandate. And throughout the whole 3 days, we kept talking about awareness. So there's a need to increase awareness among healthcare providers and patients of the need for and general effectiveness of cancer rehab. And as we've said here today earlier, that is both in the oncology world and the rehab world. There are a lot of people in the rehab world who are a little nervous about taking on people with a history of cancer. So those consensus statements will be published in Current Oncology in February 2013.